Hey everybody, welcome to PermanenteDocs Chat. I'm your host, Alex McDonald. You may be wondering why I'm wearing this ridiculous outfit. Well, it's July, and July is summertime and UV safety month. And today we're very excited to be talking about skincare with our esteemed guest, who's the Chief of Dermatology from the Southeast Permanente Medical Group, Dr. Elizabeth Seidler. So Dr. Seidler, thank you so much for joining us. I'm actually going to take this off because I can't see through those sunglasses. So Dr. Seidler, thank you so much for joining us today. We're going to jump right into this. We're going to keep this fast pace. If you guys have questions out there on Zoom land or on Facebook Live, feel free to drop them in the chat and we'll try to get to them as well. So Dr. Seidler, thanks so much for joining us. Tell us who you are and what you do.
Sure, thanks for having me. I'm Elizabeth Seidler, and I'm a dermatologist and Chief of Dermatology here at the Southeast Permanente Medical Group, which is in the Georgia region. And I'm excited to be here. Thanks for having me.
Awesome. And again, like I said, July is UV Safety Month, and so we're going to be talking all about skincare. So tell us what are some general recommendations you have for just skin, summertime skin safety and skin awareness in general?
Yeah, absolutely. So, there's definitely some things that we can tell our patients to practice on a daily basis that can help them protect their skin. One is, sunscreen, what to look for on the bottle, things that they can look for, how to apply it, and then sun protective measures that they can take in addition to sunscreen, as sunscreen really is only one part of, there you have yours, is really only one part of protecting our skin. So in terms of things to look for on the skin, on the actual bottle of sunscreen, there's kind of three primary things. So the first thing to look for is SPF, or sun protection factor. This is a measure of UVB protection. So UVB is predominantly responsible for burning or sunburn. So essentially SPF is a measure of how protected you are against burning with that number. The second thing to look for is broad spectrum. Broad spectrum, does your bottle have broad spectrum?
It does.
Good, so that means that it has UVA protection. There's no quantified amount of UVA protection on the bottle, so they use broad spectrum to indicate that it has UVA in addition to the UVB protection. UVA is predominantly responsible for aging of the skin, but both UVA and UVB can contribute to skin cancers. So the third thing really to look for is whether it's water resistant or not. And that will tell you either 40 minutes or 80 minutes, and you'll know how often you need to reapply it. So those are some things to look for on the sunscreen bottle. In terms of how to apply it, really, you can use something simple that sometimes we'll use called the teaspoon rule of sunscreen application. So 1 teaspoon for the head and neck and face, 1 for each arm, 2 teaspoons for the torso, and 2 teaspoons for each leg.
That's the front and back of the torso?
Right.
Okay.
So that comes out to a little bit more, or about 1 ounce of sunscreen to cover your whole body.
Okay. I've never heard that before. That's great. That's great advice. I never know how much to apply on. I'm putting my kids' sunblock on. They're fighting me at the same time too. So it's nice to know how much you should apply to.
Yeah, and a lot of us don't apply as much as we should to get the full protection out of the sunscreen.
Yeah.
But then the other thing to remind patients about too is other measures to take to protect the skin. As we mentioned, sunscreen is really just one part of sun protection. And like we were talking about, a lot of people are not actually applying as much as they should to fully protect their skin. So things like hat and sunglasses, like you had at the beginning of the video, to protect our skin and our eyes, as well as seeking shade, or bringing shade like an umbrella if you know you're going to be in a situation without any shade, and trying to avoid the sun when it's brightest between 10 a.m. and 2 p.m. or at this time of year, sometimes we'll even recommend 4 p.m.
Okay. Tell us, now I've heard lots of different things about sort of the SPF, sun protection factor, anywhere from 5 to 80. And I've heard some people say that really in real life and actual practical application, anything above 30 is really not that effective versus the lower numbers versus the very high numbers. Can you help give us some clarity on that, what the SPF specifically should be and is more better?
Yeah, definitely. So we always recommend picking an SPF that's 30 or higher. It's true that after about SPF 50, the increase in protection is somewhat incremental. That being said, like we were talking about, a lot of people aren't really applying as much as they should be. So the protection they might actually be giving themselves by just applying a thin film is less than what's on the bottle. So that is kind of why we, in part, recommend getting a high SPF.
Got it. That makes perfect sense. And then you did say sort of the waterproof versions we can apply every 80 minutes versus the non-waterproof should really be reapplying every 40 minutes. Is that correct?
So, the bottling, the wording on the bottling has changed relatively recently in the past several years to actually remove words like waterproof and instead replace it with water resistant. And there's really two, they can either be 40 minutes or 80 minutes, it's those two categories. And so the application of sunscreen should be done, reapplication should be done every 2 hours regardless, but potentially more frequently based on what the bottle says, 40 minutes if you've been in the water or sweating, or 80 minutes if you've been in the water or sweating.
Okay, got it. That makes sense. I'm actually looking at my sunscreen right here, and it says water resistant 80 minutes. And it's the reef conscious formula too, for those of you that go swimming in the ocean.
Perfect.
Awesome. Tell us, obviously, long sleeves, hats, things like that are obviously very important as well. Is there a point where I've had patients say this to me before, I'm too old to worry about, skin cancer. I'm already old and wrinkled. Like, I don't care as much. And I always try to tell them it doesn't really necessarily matter your age. You're still at risk of sun damage. Can you give us some clarity on that? I have heard that particularly the risk of melanoma is due from sun exposure under the age of 30, but anyone really can be at risk regardless of their age. Can you give us some clarity on that?
Yeah, absolutely. So, when we think about sun exposure, we think about it in terms of cumulative sun exposure over a lifetime. So it does add up, it does build up over time. So asking about patients' exposures, where they grew up, kind of what activities they've done, maybe they worked outside over their lifetime, all of that kind of adds up to an increased risk of sun damage over a lifetime that could put someone at increased risk for skin cancers.
Okay, so it's more about the cumulative effect than any one-time exposure.
Exactly.
Great. Can you remind us about the ABCs of skin examination? If there's moles or lesions, it's a helpful mnemonic that I always remind my residents and my patients as well. Can you go over those with us? And what are those ABCs and what kind of features might warrant more concern or biopsy or other workup as well when we're doing a skin exam?
Yeah, sure. So I agree. The ABCDEs are a good way to educate our patients and something that oftentimes we can give them in our after visit summary. So A is for asymmetry. If if you draw a line through the lesion, if one side is different than another, it may be something that's worrisome. B is for border. There should be a relatively smooth border. If there's any jagged edges to a lesion, that may be worrisome. C is color. There should be one uniform color within a lesion and not multiple colors of brown, blue, black, white, gray. D is diameter. Anything larger than 1 centimeter may be worrisome. But E, I find, is really the most critical one if you're going to remember any of the letters, which is evolving. So sometimes someone may have a large kind of atypical looking congenital nevus, but they've had it there their whole lives and it's been stable and unchanged. So really more important is something that's evolving or changing over time. And that speaks to, other things that might be concerning in lesions, anything that's new, growing, changing, bleeding, a sore that's not healing. Those would be things to look out for.
Great. I've also heard about A, B, C, D, E, and U, the ugly duckling. If you have one mole or one lesion which just looks weird compared to all the other moles or nevi on the skin. Is there any truth to that?
Yeah, I love the ugly duckling sign actually as well, because it's true that some people tend to make moles that look similar to each other on their own skin, which may look different than someone else's on someone else's skin. So some people tend to make moles that almost have a pinkish hue, but they're all kind of like that. Somebody else might make all darker kind of moles. So when you're looking at someone's skin, one that kind of stands out as different from all the rest can be helpful.
Great. That's certainly helpful as well too. Now I do practicing family medicine and primary care, I'll often do a lot of biopsies right here in my office, just to expedite care. And so when I'm doing particularly skin biopsies, I'll usually use a derma blade and do kind of a superficial shave to minimize scarring and things like that. Are there any times where you would recommend sort of a deeper shave, or maybe a wider excision for a lesion versus just starting with a superficial shave?
Yeah, absolutely. So if you are really concerned about a melanoma, for example, that's when you want to be able to get kind of under the lesion as much as you can. And part of the reason for that is that the determination of the melanoma is somewhat based on how thick something we call Breslow thickness, which is how basically deep the lesion is, as opposed to something like a basal cell carcinoma where it may be fine to kind of just take a part of it.
And it remind me, it's 2 millimeters is kind of the important demarcation between whether we need to do more workup versus just sort of thinking that a melanoma is more isolated. Is that correct?
Well, so 1 millimeter is kind of the hard and fast point at which you may need to do more workup, but there is a gray zone that sometimes can be a little bit thinner than 1 millimeter, kind of based on some other features that might be present.
Okay. Anytime I try to do a shave, if it's something I'm really worried about, I try to get a deeper shave to at least 2 millimeters or so, just so we can get a little bit more. It's always better to have probably more tissue for diagnosis than less sometimes as well. Is that a fair practice?
Yes, absolutely.
Okay.
And absolutely, especially if it's something like on the trunk, you can do a nice scoop shave. Where that can sometimes be, sometimes where it can be tricky, I guess, would be like on the tip of the nose or something like that, where you may want to, that's where it can basically become tricky, where you want to preserve as much not normal tissue as possible.
Right. Yeah. I actually took a basal cell off a guy's nose the other day on biopsy and sent him to my Mohs colleagues to get all the basal without unnecessary damage to the residual tissue as well too. So it's always helpful to have our dermatology colleagues do that. So thank you. So let's change gears a little bit here too. And I mean, different pathologies and skin lesions can look different on different skin tones as well too. So, what are some important considerations when examining the skin and caring for patients with different skin tones as well?
Yeah, absolutely. So one thing to always consider with patients with different skin tones is that one thing in particular that can come across differently is inflammation. So inflammation in lighter skin tones will oftentimes be erythematous or kind of red or pink in color. In darker skin types, inflammation can come across as hyperpigmentation and sometimes even purple in color. So that is something to consider in terms of all sorts of conditions where there may be inflammation.
Okay, that's a great point. I don't think there's any truth to this, but I want to get your thoughts too. Some patients who have darker skin, say they don't have to worry as much about skin cancer or sun exposure without SPF. Going back to our earlier conversation, is there any truth to that? What do you tell patients who come in giving you that information or that kind of thought process?
Well, the reality is that anybody is at risk for skin cancer regardless of skin type. That being said, people with a darker skin type do have a less of a risk of skin cancers, but it is not zero. And people with any skin type can present with a skin cancer.
Okay, sounds great. After 2 years of staying home and isolating, I know a lot of people are going out this summer and spending more time outside, more time at the beach. Are there any tips patients should be aware of and physicians should offer their patients regarding kind of re-entry into the outdoors and sun exposure, maybe not having much sun exposure recently?
Yeah, well, absolutely. So as we're all enjoying the sun more and more, we do want to be cognizant of the things that we talked about with regards to protecting our skin, really from the whole time that we're outside. So not waiting until, we're outside after 2 hours or something like that, but really being prepared with our sun protective measures, sunscreen, hats, sunglasses to protect our eyes, umbrellas potentially, or, seeking shade when we are outside.
Yeah, so just the standard kind of traditional sun protective factors or steps we should all take all the time. Any new? We just got a question in the chat. Are there any changes in the environment right now that sort of making sun exposure and skin damage worse than in the years past? I know there's been a lot of discussion about the ozone layer and things like that. We haven't heard much recently. Is there any new or evolving evidence regarding changes in sun exposure?
That's a good question. So there is one interesting thing that has come out of the kind of the pandemic, I guess you could say, with regards to things that we're doing for trying to kill off viruses. So typically when the UV, most of the UV light that is entering our surface, the Earth's surface, is UVA and UVB. Pretty much all of UVC is absorbed by the ozone. But interestingly, a lot of people during the pandemic were using UVC to kind of disinfect or decontaminate things. So there is this, potential for exposure to UVC, which the risk of that is not totally clear, but that is something that sort of is an interesting thing that more people have been exposed to in recent years. In terms of the ozone specifically, there's not a ton of data that I'm aware of at this point.
Okay, that's great. I know here in our office, we have a box that you put the goggles in, you close the doors and you push a button and it uses, I think, UVC to decontaminate the goggles. And I always thought it seemed a little far-fetched until I started reading about some of the evidence that actually truly does disinfect as well. So, but again, you can't turn it on unless the doors are closed to avoid exposure to people around you as well too. That's just interesting. I hadn't thought about that UVC exposure. Tell us more about any kind of new or emerging issues right now in the field of dermatology, or anything that we should sort of keep our eyes or ears aware of.
Well, one thing this summer that we all, and especially as dermatologists, have really been keeping our eye out for is, of course, monkeypox.
Of course.
And so, typically it will present with a prodrome of fever, malaise, lymphadenopathy, followed by a skin eruption. But there are cases, including here in the United States, of patients presenting with the skin eruption followed by systemic symptoms, and in some cases, the skin eruption only.
Interesting. How often are you seeing that, just the skin eruption only?
Well, it's, that's a good question. I don't actually know the specific number. And we've only had 3 cases here in Georgia, so we're not seeing it that much. And that's another thing actually to keep in mind is, although we all have our eyes out for it, it's really not highly contagious, and the risk for the general population still remains low.
Got it. Okay, that's always good to know. And my understanding is when the skin lesion is little vesicles, and you really need to sort of puncture the vesicles and get a sample of the fluid to send that for testing. Is that correct?
Exactly. Okay. Right.
Perfect.
There will be fluid or pus kind of in the vesicle, or in the bump.
Perfect. It's always good to know that my information is not completely off base. It's hard to keep up sometimes. So, we have a couple other questions here in the chat, going back to the sunscreen issue. For those of us old enough not to have used sunscreen in our youthful years, what treatments do you recommend to remove sun-related damage, flat age spots, solar lentigo on the face and neck, Are factors like laser therapy or retinoids beneficial at all for the sun, kind of the chronic sun exposure, sun damage?
Yeah, so there are a lot of different things that can be done. So of course, I recommend talking to your specific dermatologist, depending on what kind of things are going on in your skin. But sometimes people do use retinoids. There are things like, Effudex or fluorouracil to kind of field treat an area. There's even, PDT or blue light, some people will call that. And there is actually more data around things like niacinamide or nicotinamide, which is, the active form of vitamin B3, which is starting to be used as a chemoprevention for people who have a history of SCCs and BCCs.
Oh, interesting. That's really good to know. I was not aware of that. A few other questions here, also going to the sunscreen issue. What about different types of sunscreens? There's some mineral-based sunscreens. The one I have here says very clearly mineral sunscreen lotion versus the chemical-based sunscreens. Is there any evidence that one is better than the other?
So that's a great question. And chemical sunscreens are essentially, absorbing the UV light, whereas mineral are kind of considered physical blockers that reflect the light. Now, that being said, a lot of the physical blockers are in nanoparticle size, and so they do also absorb the light in some ways. Generally speaking, physical blockers or the mineral sunscreens tend to have less allergenic potential and can be better for sensitive skin. So chemical blockers can be a source of allergy, contact allergy, for example. There's also been a lot of controversy over the years, claims that potentially chemical sun blockers are toxic to our health or cancer causing themselves. The reality is with that, there's not great scientific data to support those claims. So that's something you can tell your patients if they are concerned about that.
Great. So just use sunscreen, bottom line. Doesn't matter what type, essentially. Is that fair?
Exactly. That being said, some people do have very sensitive skin. And so then in those patients specifically where they say, I react to so many things, fragrances and this and that, then choosing a mineral sunscreen might be best for them.
Got it. Great. All right. One more question here from the chat. This is great. We're having a lot of audience participation, which I always enjoy. Are facial moisturizers with a built-in SPF sufficient, or do they also need to apply sunscreen on top of that sort of daily moisturizer SPF routine?
So really have to look at the bottle. If it says that it's SPF 30 or higher and broad spectrum, then that will be sufficient, as long as you reapply it every 2 hours.
Right.
But a lot of kind of makeup with sunscreen in it will just be an SPF 15, so that may not be enough.
Okay, great to know. Awesome, this is wonderful. Or we could go on and on all day, but I'm going to ask you my one last question, and then we'll wrap up here. So tell us what makes you most proud to be a Permanente physician.
So I'm most proud to be a Permanente physician because, well, two things really. One, I think that our model, patient-centered integrative care that really focuses on preventive medicine, is really the best way to practice medicine and is the future of healthcare. And secondly, I'm proud to be a Permanente physician because of all of the other physicians in our group that I find to be such high quality, and I feel comfortable with the care that we provide in any part of the system.
Awesome. Well said. I could not agree more. So, well, thank you, Dr. Seidler, for joining us and giving us your thoughts. I really appreciate your time and expertise here, and I'm sure our audience did as well.
Well, thank you. Thanks for having me.